cost effectiveness of EMTCP. But to date, there have actually been no studies that have assessed the actual cost of integration or the cost effectiveness of integration in family planning and HIV care. And of course, this is very important. It's important to understand the costs in order to be able to know whether or not it's scalable in the context in Kenya and in other settings. And it's important to assess the cost effectiveness in order to be able to prioritize resource allocation. So, in order to estimate the costs, we basically spent a lot of time with Dr. Nyanza and the team to try and interview them and to review the financial records. I owe a great debt of gratitude to George Limbo, the financial manager for the project, for keeping such amazing records in order to be able to estimate the costs of space modification in the clinics in terms of one-time costs, including equipment, recurring costs of supplies such as family planning and other family planning supplies. And then finally, the cost of personnel, which included, as has been previously discussed, substantial training, mentoring of nurses on site, and supportive supervision by the administrative team. So in order to estimate the cost effectiveness, we basically compare the costs in the integrated and the non-integrated costs in the non-integrated sites, and then divide it by the difference in the effectiveness in the two sites, types of sites. And as we've discussed in our other presentations, effectiveness is the use of, is basically determined by more effective family planning. All right, so we've discussed this before, but basically there were 12 integrated sites who had a total of 5,900 patients, and 6 non-integrated sites who had about 5,100 patients. The non-integrated sites were actually slightly larger than the integrated sites overall. So the total cost of integration across the 12 sites was about $66,000 for the entire 1-year period. And the total cost in the non-integrated sites was about $27,000. And the difference is about $39,000. And so basically what that broke down to in terms of the difference was that it was about $1,000 per site to integrate and about $7 per patient to integrate. And the reason that the costs in non-integrated sites were so high is because it did include substantial system strengthening to introduce new methods of family planning. Our colleagues are going to come this up, so I also wanted to check. Basically, almost all of the costs for these interventions were associated with personnel time to train, to mentor, and to provide supportive supervision. We had almost no costs associated with the renovation of space. Generally, it involved moving beds from one room to another, or filing cabinets from one room to another, or sometimes from one clinic to another. But there were essentially no modifications in space. Equipment and supplies was higher in the integrated sites compared to non-integrated sites, but we think that has to do with the increase in family planning, and therefore the increase in associated supply. And then all of the personnel costs were higher within each of the categories in the integrated compared to the non-integrated sites. And so just to break this down, basically about half of the difference in costs were associated with additional training that was needed to facilitate integration. A lot of this had to do with staff turnover at the sites, and specifically because the integrated sites were smaller, if a large portion of their staff, which often was just 1 or 2 people, happened, then we had to retrain the entire staff. And then similarly, other costs such as equipment and supplies made up just about 20% of the difference in costs. And you can't even see space on this bar, it represents only 2% of the difference. This graph is similar to the one that Dr. Grossman presented about the effectiveness of the interventions. As he discussed, we observed about a 20% increase in the integrated sites in more effective family planning and dual use of more effective and condom use, and about a 12% increase in the non-integrated sites. So these are the pieces that go into establishing the effectiveness piece of the equation. So we looked at the proportion of any uptake in more effective family planning, and then we attributed that to the total patient population in each of the sites, for a total of about 1,150 additional patients using more effective family planning in the integrated sites, and about 585 more patients using more effective family planning in the non-integrated sites. And then this is the cost-effectiveness ratio that I represented earlier, where we subtract the total costs in the integrated sites from the total costs in the non-integrated sites, and divide that by the additional patients using more effective family planning in the two types of sites. The result is an estimated cost of $68 per additional patient using more effective family planning in these sites. So previous modeling estimates have suggested that just not using integration, but using outreach models have suggested that the range of costs for provision of family plans between $6 and $113 per patient. And so our estimated costs were very similar or within the range of these previously published estimates. As I mentioned before, no study has actually been able to look at the cost of integration. Similarly, our relative increase in family planning, which was 8%, was similar to the estimates that have been used in previously published modeling papers. But again, no studies have actually looked at the proportion of increase that might happen with integration or even with outreach. We feel that integration is a cost-efficient and cost-effective way to increase family planning use among HIV-infected women, and we feel that these results support the current planning policy of integration of family planning into fertility care. Thank you.
Thanks, Shirley, for that very interesting finding of the study, which focuses on costs, which is an important aspect. Before we go into the discussion, I can see your hand. Right, so just keep it there. We're coming to you shortly. We have Professor Craig here who will just take us through one slide on acknowledgement. It's important sometimes. It's not always important for acknowledgement.
Thank you very much for this opportunity. Obviously, a study like this doesn't take place easily. It takes really a village, many villages to come together. So I do want to take some time to thank specific groups and individuals. This is a concept activity. I remember meeting with Dan in the office about 6 years ago with UCSF, and I'm so happy for everyone should be so proud come to fruition. So I want to thank the study participants in Rwanda, Musike, Kisumu East, and Suba districts in Nyanza. Study coordinator, Luciana Nono, presented Richard Steinfeld, who's somewhere. Very excellent and proud. But Goreti, Akini, Agunipi, Shiko, Ngori. Family planning study nurses were integral to the training and the monitoring and continued training of the 18 sites in the study. The FACES, Family Education Services leadership and their staff, the data team, both at UCSF and at Emory, the Reproductive Health and HIV District and provincial coordinators, the community and clinic health assistants, which are part of the FACES program, community advisory group members, which existed in each of the 4 districts, and of course, the Bill and Melinda Gates Foundation and the Times Africa Foundation for their generous support of this important study. Thanks so much.
discussion, which we have about 20 minutes or so. And thanks to the team here for giving us, we made savings along the way, and we're going to read in the discussion. But before that, let me just take, as a chair, give you a bit of context and remind you on some of the key highlights that have come up, so that as you're engaging with giving up comments, focused comments and questions, they will probably help you to sharpen those up. So the HIV care and treatment centers or facilities do present an opportunity where clients do come in with very high unmet family planning needs, as it was demonstrated. This cluster randomized clinical trial basically reinforces and strengthens the body of knowledge, especially because this is a study design. It really helps to do that, in addition to the other studies that have been done before, which were mainly observational studies, or that kind of study design. So in this presentation, what's coming out very clearly is that by integrating family planning into the HIV care and treatment centers, has resulted in increased uptake of use of more effective family planning methods. That's important. Of course, the one which didn't come out very well was the dual method use, or dual protection, which did indicate that it really rose significantly up. On the aspect of knowledge or attitude of the clients, with respect to the men, there was a reduction in the negative attitude of men, and this would definitely help in reducing the obstacles that are there to prevent uptake of family planning services. Definitely, intercouple communication will be key here, and there is this note of this major gap between those who are actually using the method now and then those who plan to stop or actually delay fertility. So then when it comes to satisfaction, it looks, from the findings, patient satisfaction was highest within the integrated sites, and this basically maybe is a reflection of what really went in the inputs to strengthen the family planning services within the intervention sites. There was a notable increase from 85% to 89% and later on to 96%, and that was important. Cost effectiveness, yes, this is a scalable, feasible, cost-effective, cost-efficient, integration, form of integration, where family planning is being introduced or integrated in the HIV care and treatment center. This corroborates very well with, I was checking the global evidence that indicates the 5 good reasons why one needs to integrate, especially family planning, into HIV. There is a statement which one of the reasons is integration is cost-effective, cost-efficient, it improves access to healthcare and increases financial sustainability. So I think this really reinforces that particular reason. So with that then, basically set the stage, provided the framework within which you could actually make your comments and also put in your questions. We will start with the gentleman. We have a movable mic. The lady, the man here, sorry, who has stood up. Yes.
Thank you very much. It's a very commendable presentation, fascinating study.